Miss Smith. Miss Smith, are you okay? Are you okay? Somebody help! No. It's a mock code. You good. Can somebody get the code card? We got the board.
KB, everybody.
Are you really open it or?
You can bring it to the Has anybody called star 5? Yeah, we absolutely have to do that. Who's going to be in charge here?
Just go bag or be the relief person.
Can we turn that thing off though?
We'll relieve on it next time. Alright, who's doing meds?
Who's in charge?
Yeah.
I'll do meds.
Alright. Alright, I'll record.
Who's our leader? Who's our leader?
Yeah, who's our leader? This is the doctor. Still no call.
Doctor's supposed to come until he gets here. Okay, are all the assignments given?
Yeah.
IBN.
Pass on.
Who else is doing Tesco practice?
Right here, she's on it.
5, 6, 7, 8, 9,
Got the airways.
10.
Do we have somebody recording?
Me.
Yeah.
She's recording.
Okay,
Oh, the compression.
so I want to do something. I want to stop here. I want to talk about something.
Okay.
So, I'm Shannon, by the way. I'm one of the rapid response team nurses and the code nurse for the hospital. You guys did really great. I'm going to stop because we're going to do bits and bits, okay? So I did hear that someone already said they had called star 500. If this is a patient that is on an inpatient as we switch with the COVID, the next thing is I need someone to call the primary team. So let's say it's surgeon. So it's a 2-call thing. For your normal patients, if they had a code, you have a different response. But for these inpatients, make sure it's star 500, which someone did confirm that they'd already called that when they heard the code bell. And then make sure you call that primary team as well. Because you may not have a code leader for a little bit, right? And I did notice that someone said, who's the code leader? What we did was chest compressions. People got in, people assigned their roles, but what you didn't do is the thing that's gonna save the human being the most, which is a defibrillator. Because if it's VTAC, VFib arrest, first 2 minutes, which we missed, looking at the clock. We didn't get that on to analyze if this is a VTAC, VFib arrest. So we had someone doing airway, we had someone doing good quality chest compressions, which was what we had to do. But we didn't do this. We got this, we had a roles assignment, but the thing that was gonna save the patient first, get this Zoll off the cart, on the bed, on the patient, as fast as you can. Now we're not doing the pads, we're not opening them up just so we don't wanna waste them. But the one thing that's happened, I saw you guys, you turned them very quickly, you put them on the backboard. At that same time in that turn, that's when you put those pads on. That's a one-stop shop, so you're not back here, you haven't stopped, you having to do it again. So when you go and get that backboard, someone's getting that, someone needs to have this, you had to reach and grab it to stop what you were doing for that. So that's a part of, rolls are great, but the first 2 minutes is this. So when you go to turn, and the one thing I've seen multiple times, is because it's so shocking that someone's coding on you, is that they'll put the pads on, you're like, you got that, but it's on the right side and not the left. And so even if you go to defibrillate that, you're shocking the right heart, you're not shocking where we need to be. So always remember that when you go to turn, to make sure, is it my right, left, because that does happen. I've seen it honestly at least a half a dozen times in doing these codes. Real codes that we had it on the wrong thing, real codes that needed a shock, that we shocked the right heart and not the left, the big left ventricles. So I wanted to stop it because I want to make sure that we don't go through this whole roll without understanding that this is your life-saving device. This is an AED. If you don't want to use it in the large mode, which I want to show you that really, really quick so you can see it. You're calling a code, you had people coming to help, you called star 500, you called the primary team if this is going to be a patient that's an inpatient status. Sorry about that. You get them on the backboard at the same time you're putting that patch on the back of them. If you don't feel comfortable in the whole big, it goes like this. I'm going to show you on this particular one. When you turn it on, and it always makes noise, right? Which is horrible with this noise screaming. You've got people coming in asking, who's the leader, who's the leader? It becomes a little confusing. I'm going to silence it really quick and save your paper. But if you don't like this large thing and you're just trying to read it and you don't know, all you ever have to do is put it into AED mode and hit analyze. That way, if you're not recognized, you're not great on VFib, VTech, you can't tell if that's just movement. You stand clear, you allow it to go into defib mode. It'll tell you shock. If it says no shock advised, you just do good quality chest compressions. So you know that when someone comes and says, what was the first rhythm? It was in defib mode, it said no shock advised, we started compressions again. That's all you have to do instead of, because some people don't like the full monitor where you go open and you get it all on. The one thing I want to show you guys very quickly is when you're doing high quality chest compressions, when it's with that puck, don't ever take the puck off. You have that X puck. People sometimes take that off. That is the see-through quality CPR. That is what's telling us in these areas how deep and good our chest compressions are. And that is what it'll say. Push harder, slow down, push faster. It gives you both the rate quality, but that's what that puck is. And I've also seen it pulled apart where you've got the triangle here. The puck is kind of up here, but you're pushing on the triangle. It can't read your quality CPR, so keep it exactly as it is. Don't pull that apart. That area here is what tells you chest compressions. So if it didn't say shock, and it says continue doing chest compressions, whoever the leader is, before you're offering to do epi and all of that, you can say good quality CPR. And it'll talk to you through the whole thing as well. So
where is the puck?
The puck, if you pay me that.
It's in there?
It's already built
Okay.
in. So just to give you an idea, that little cross thing, that's the puck. And it very easily can get torn apart, but once you do that, it cannot read your quality chest compressions. So keep it just like this. Don't separate that two. That is what gives the feedback on how fast and how deep you're compressing the chest. So that's when you pull it apart and you'll put it straight on the chest, just as it shows. And that's a great time when you're putting that backboard on, because now you brought this later. What are you gonna have to do? You're gonna have to turn them again, which means an interruption in chest compressions, but we didn't hit the 2-minute mark for, could we shock them? And we didn't shock them. So it was a beautiful job, and I got airway. I'm doing good chest compressions. I very clearly said I needed help. People said, I'll do the documentation, I'll be medications, but what's gonna save them, if you can save them, is this. The other thing is, if it gets crowded, and you guys know, I always say this, if you just take this off and bring it in and leave the cart out there, it allows, because if we're rotating chest compressions or anesthesia is coming in trying to it becomes a pain in the tail. So one of the great things is, you're grabbing that backboard, someone grabs this, the cart can stay right out here. It also acts as a nice variable for people coming in and doing this. Don't you love when this happens in a code? They're not doing anything, and you're like, okay, either you're gonna help chest compressions or you need to go outside. So that's a great thing, is this offers kind of as a barrier for people just kind of wandering in, so that you do have the right. The other thing is that one of the things I've noticed is when people yell, it becomes very hard. Let's say you were the code leader. The code leader really should be here. They should be the clearest person giving. And if you're the RN being the code leader initially, because you don't have other providers coming in yet, it's perfectly fine to say, okay, everyone, stop yelling. I need you to not yell. Don't come around. It's perfectly fine to be the leader in that sense. And then when you have a critical care attending or a hospital or just someone else that you're willing to defer the lead off of, you can brief them quietly. Say, we shocked, we started CPR, we've done 2 minutes of CPR, we gave our first epi, and then you can back away and you can see if you're needed for help, anything else. Can I go and do chest compressions? The other thing is, very quickly, make sure that we have enough people to do chest compressions, because nothing is worse than getting tired. And if you haven't done chest compressions for 2 minutes, it is really hard. 2 minutes of chest compressions, even with really great, healthy people, is really hard. You'll start seeing your depth is going down, your speed is going down. So to have people willing, at least 4, because even if you did it for 2 minutes, you're back off for 2 minutes, you're back on, you are still not recovered yet. So it's okay if I do chest compressions, I can back out, recover a little bit, and make sure the next person is ready to take over. They're standing behind. It's very hard to have multiple people on either side of the bed doing chest compressions. So one side of the bed really helps. So if this weren't here, if we did this right and you pick it off, you know, it's always painful because you got to unhook everything. But let's say we've got it right here. This is out of the room. It makes it so much easier to line up for chest compressions. I could even be like, okay, this doesn't need to go out. We can get this out of here. Low versus get the card out of here. Becomes very confusing. In a code, I remember a lady just went down. She was on isolation, not PUI, but isolation. People were in there just doing what they needed to do because they ran in there because they saw her on telemetry. But then they started throwing gowns. I got like hit in the face with a plastic gown, and I went, and this is what I tell you to do, use your teacher voice, please don't throw things. And that's literally what I said, because if I start yelling, everything gets anxious, everything, nice, low voice. You can even tap the code leader, I'm documenting, and then you're out. I've got medications, and then I'm out. Because the more we yell, it's harder to understand. Did someone say they needed medication? Because the best thing you can do is to be the badasses that you are. Ooh, that was on the film. And do it well. But that's what we should be, right? Take it calm. We know what we're doing. We've got this. Because chaos begets chaos. Calmness works a lot better. So, you want to try it again?
Yeah.
All right, we'll get everything set back up again.
Yeah.
And we'll put this back on the card. Someone got the AccuCheck, which does help if we're looking at H&Ts as we go on into the. Let's make it look like a real code. Like when you really gotta. You can be on that bed if you want, girl. We won't really do chest compressions.
I don't have no problem doing that.
But let's make it look like in our real life.
Do we have any expired
Pads?
pads?
I looked all over this morning to find some
Printed this
expired
off
pads.
because I
Do
was
we have
able
an
to sign
expired
the
one?
lunch exchange today.
We
So
got
Yeah,
rid of them.
Can you use it?
absolutely.
This
you can
is
use
in the
that.
drawer, so.
Yeah, it is in the drawer. So the
It's
clipboard
dummy.
that's there, you
Do we
can
have
grab
an
it.
extra one?
Absolutely.
And can we,
Perfect idea.
do we can we get these doors out of the way?
If you needed to break them open, you absolutely could. If you feel like breaking it open causes too much ability for people to straggle in, you can do that too. You guys know what works in your world.
Like shorter than before.
I like the pattern. No,
But I think if we do have a stool, I think we have an orange one. It may be in this closet. If not, I can ask Karen if we can order one. That shouldn't be a problem.
Like we literally have like a shelf
we
above
used to have a
where the
stool.
doors are, so.
But they got rid of them though, yo. I'm gonna get over here by you, so I'm out of your way.
I'm gonna be pulling that chair over here.
Doing
Yeah,
that
do you guys
other-
have stools?
No, we were just talking about that, cause I was like, I'm too short.
Maybe and those don't go down like the other beds do.
Right.
Maybe a purchase you guys think about having.
Well, I was just telling
We were
her
just
that
having
we
a
were,
lot of
I was gonna ask Karen, yeah.
All right, so are we ready?
I think you
Oh,
are.
I'm ready.
Ready?
What am I?
Okay,
Don't
get
talk.
set, go.
Close your eyes, please. Miss Smith, are you okay? Hey, I need some help in here. Can someone call star 500? Call code? Hey, she just stopped. I can't feel a pulse and she's not breathing. Iris. Let me call star 500.
All right, let me get some.
Okay.
Airway
Start
here.
compression.
We got the defibrillator. Yeah, so
Oh, you have that.
Did we get the?
we're gonna roll the tape.
Wait, we're gonna get the
We have
pads
pad
at the
ready?
same time.
Watch the cord.
Okay, roll, 1, 2, 3. Back pad on.
Are we opening something?
No.
Let me put the pad on.
Put pad on.
And we're going
Front
back.
pad on. I called the Russians. She called it. I called the
6, 7, 8,
Can you be the,
No, that's
who's
fine.
the team
Turn it
leader?
on. It says shock advised. Shock advised.
Clear.
Clear, everybody. What is
Charging.
the rhythm? Who's charting?
I'll chart.
Okay, you're
Ready
charting.
to shock. Ready to shock.
Shock given.
Shot
Airway.
given. Resuming compressions.
Somebody get on the airway.
4,
Okay.
9,
Compression.
10, 11, 12, 13,
Start an IV, please.
16, 17,
That'll be
9, 30.
Good compression.
1, 2, 3, 4, 5, 6, 7.
Can you turn off the thing over there? How's the patient doing? Did somebody call the team? Yes, they were called. Thank you.
Yeah, I don't think I'll be very
Are you getting tired? You doing okay?
So that, is that 2 minutes?
Yep.
2
Okay.
minutes.
Is it time for
Yeah,
You're really
that's
for
your
us.
minute.
Wait, hold on. I'm sorry.
Do you let's get,
I wasn't
some
expecting
epi?
that,
We'll
but
get some
okay.
epi.
I'm good, go ahead.
You've got epi.
1 milligram.
1 milligram of epi going in.
Timer got that. What's the monitor?
You're still doing 2 minutes, so you're not gonna see it until you
30.
stop. Alright, so let's say that's been 2 minutes. Pause. What do you say? It could be a ROSC, it could be a rhythm. If you have a rhythm, let's say this looks like sinus tachycardia. Do I have a pulse with this rhythm? Because then you may have gone from a shockable rhythm to a PEA. So every 2 minutes, find out what your rhythm is, if you have a pulse with that rhythm. And if you don't know what the rhythm is, you can always hit analyze again. You can say it looked like sinus, but it said shock advised. You can always do that. It said no shock advised, continue CPR. So always remember that you can do that. Here's the other thing. It felt like I had 2 team leaders, right? And that's okay. That's okay. But if you're going to be working with someone or you feel like that person is needing a little bit of help, stand beside them. I think it's time for epi. Stand beside so you don't have competing discussions. That's perfectly fine. It happens all the time, but that's how if you want to have co-leaders, that's fine. Here's the other thing. It's hard when you're a leader and you're trying to look. So the great thing is, turn it here. You can still be doing all the analysts, but it's very easy for the leader to be able to see what's going on, to be able to say, okay, at 2 minutes, pause compressions. Let me look at my rhythm, continue CPR, or maybe it's a shock advised. It's time for epi. The other thing, what we didn't have, what we had 2 so far. Were you in line to do chest compressions?
No, I called 500.
You called Star 500, so you're alert. So just make sure that other people know, all right? If you're down here, or if you're gonna be next in line, you can, I'm next for chest compressions. Doesn't have to be loud. When they step out, you can get on in there.
He's the recorder.
Okay, so you're not gonna be doing chest compressions.
Right, so, yeah.
But know at any time in a code, if someone is getting tired, they can record while you pick up and start doing chest compressions. Because if you have limited staff, let's say there's something else going on, it is okay to say, I can push drugs. I'm tired, I can't do chest compressions, but I can push meds. Give me a little bit to do that. You guys got the shock in at 1 minute, 17 seconds. That's great. That's what you're supposed to do in under 2 minutes. So you looked, it said shock advised, you cleared, analyzed, charged, delivered it, and you got right back on the chest, which is exactly what it's supposed to look like. So that was beautiful. But you see how much easier it is turning the backboard, getting that pad on?
Yeah.
It's like a one-step shop. So you can get all of that done.
We should have pulled the bed out for that.
You know what, and
Airway
sometimes
could've
it's
been at
not
the
in
head of
there.
the
Yep, you can't be at the head of the bed. At the 2 minute mark, that is perfectly fine because I can feel a pulse while you're moving the bed down. That's perfectly fine. The other thing is whenever you move the head or a bed, announce that you're going to be doing it. Don't do it loud, but because if I'm trying to stick her and you guys are moving this bed, that's just a risk there. Oftentimes your patients probably, do they have IVs? Post, you know, so you don't really. Most patients do, and then when the team comes, the RNs, the TRNs can put an IO in, get you a central line in 2 seconds. No more of the days where we're like, put the lines in the groin and do all that during chest compressions. We'll just drop usually a humeral IO in so that we don't have to worry about that. Because we do know that a little 20 gauge right here in the hand does not circulate blood very well. If you put it in the humeral, if you do an interventional radiology, when we get that humeral IO in, it is 3 seconds from here to the heart. That's what you want. Even if you put in the IOs down here in the legs, it's still a lot longer because as good as we do chest compressions, it is nowhere near as good as normal ROS. So let's say At that 2-minute mark, you got patient back. Let's say you shocked and you got a pulse back. But the code team still is not here yet, because in the first 2 minutes, they're not gonna be here that quick, right? So let's say you've got a rhythm back. What's the next thing you're gonna be doing for this patient?
Double checking the pulse, checking mentality.
Are they waking up?
Yeah.
Airway. Are they ventilating well enough and breathing? Do we have to do rescue breaths for them? Because they may have it back, we don't ventilate them, they get hypoxic again and they brady right down on us. So once you get that back, and then if it's a hard person to feel a pulse on, go carotid or go femoral and keep your hand on it. Nothing else is going on, so we don't need to give drugs right now. The heart rate's back. You're gonna let us know how they're ventilating. We're gonna start, if we have it, start attaching them to everything, because a lot of people, you guys don't have you guys have this monitor. One of the big screw ups that happens is that this becomes your baby during a code. Take everything here and put it here. Now, anesthesia, you guys work with anesthesia a lot. They love that up there for their pulse ox and all of that, but that doesn't help the code team leader, right? So it is perfectly fine to say everything's going on here. I'm gonna put my blood pressure cuff on there. You're moving for me. I love that. She's back. And then our pulse ox, we'll start switching, because this should become ground zero for you, because competing monitors are hard to deal with. It's hard to figure it out. So this can go off.
Yeah,
The other
this thing. and
this is pulse ox.
this here.
So capnography, do you guys, I know you guys use capnography, you probably do nasal, post, all of that. I don't know what your normal standard are. Do you guys know how to use this
For the
particular
ambu
beast?
bag,
For
and it attaches to the
Entitled
ambu bag.
CO2.
ET2.
If they have it to the ET tube, and if they don't, you sometimes can hook it to the mask, but what we do is, we usually plug it in after they get an advanced airway in. This little, we usually ask that there's there's always one in the top of the code card. I don't want you to worry about that. Have you guys seen it? It's a little
The clear
plastic that
plastic,
slides
yeah.
in. So, one of the things is, if you don't know how to do it, if you don't know how to get this zeroed, because this is just like an arterial line, it has to be zeroed to atmospheric pressure. So if you ever want to use this slides in. It is in the top airway thing. It's that little plastic that says peds or adult. It slides right in. It's exactly where you attach it to the ET tube and then to the ambu bag, or a vent if you needed that. But usually they'll take it off from the vent and put their own capnography on it. But if you don't know how to do that from an RN standpoint, care partner standpoint, if you go onto this, let me show you how many steps it is to do this, just so you can see it, because it cracks me up.
Come on around, y'all.
So come around this way if you can. They made this so easy. So it's trying to warm up, so you'll go in. You can change your traces here if you want to have that, but it'll go CO2. You have to, once you plug it in, it's not going to be able to zero right now, but you would go zero. It'll try. It's not ready because it doesn't have the sensor in it, but it takes a good minute or so to zero. But that can be going on. So if you're coming in there and you're waiting for chest compressions, you like, I can at least do this. I can get this going. If you're not over in the defib mode, you can at least get that zero. Because
you
once
can't
we
do it
that,
in defib mode.
you can't see it. It does. It's if you had pads on, you wouldn't be able to see it as easily. But you could still try. But you can get this going and have it zeroed out, because when they get the airway in, this gives us the reason why we look at capnography during. Do you guys know why we always monitor capnography during chest compressions?
See how good you're doing with your compressions and
So when you go from,
see when they return.
your cells, when they go from aerobic to anaerobic, only place you get off CO2, the only place is in your lungs. You don't put it out any place else. So if we start having our CO2 come up, we're blowing off enough, it means that we're doing good chest compressions. When the CO2 starts getting down to 10, 15, it starts dropping, means we're not perfusing tissues. Our tissues are just not getting, and that's sometimes where we call codes when it's 10 and we can't seem to get a CO2. Normal CO2, same thing like an ABG, right? 35 to 45, depending on your pathophysiology, but the standard should be that. So when we're doing great chest compressions and we have a capnography that all of a sudden went from 10 and it's all the way up to 35, that's a good idea that our heart is now pumping again normally and we're getting perfused all the way through. So that's why we use it, and that's why it's really helpful. How many of you guys are ACLS? Do you have to be ACLS to all work in here? So it's a standard, right? Every time I would take ACLS, I always walked out of there going, I'm a little bit nervous about the medications, and I don't really know if refractory VFib, how much amiodarone do I push? What do I do with that torsades? Guess what? You save a patient when you put them on the monitor within 2 minutes and you shock. After that, everything becomes, you're not running the code, right? You get more code team members in there. You're doing agencies, and you have, so that's the biggest thing I want you guys to take home is calm, collected, get them on the zone. If it says shock, you shock. If it doesn't, you do good quality chest compressions as more of the code team members come in. And let's say you come in and everyone looks like they're doing great. The other thing is you got 8 more patients out there, right? You can be like, I am not needed. Let me go out and keep the wildness going out there and make sure everything is okay. That's the other thing in the milieu, because standing around doesn't help anybody else. If you're not needed in the code, go and do the other good work that you do every day. All right, so questions?
Actually, I have a question.
Yeah.
And maybe you want to defer at this point, but in this era of COVID,
Yes.
are there any things that we should be approaching differently?
So we're getting ready to come out with a document, and this is one of the things I talked about with the ERC yesterday. For the most part, often they're doing these surgeries now, and as we start bringing elective surgeries back in, I believe they're testing everyone for COVID status, okay? But let's say, yeah, it's not done quite yet well, so we're telling everyone that with your, and I know you guys didn't have them all on, because sometimes it's hard when you do between your, let me see if I have mine. Oh, I don't have my good goggles. So your normal PPE is your goggles, and you should have gloves. We're saying, if you can, get an N95 mask. Do you guys have N95 masks in your?
Oh, that's a loaded question.
So, yeah, and it's hard right now,
can
it's a
find
weird
some.
thing. So one of the things that we're telling people is, let's say I'm in, and I'm doing chest compressions, it's my patient, you guys are bringing stuff in. The minute someone comes in that has a mask, even these are better than nothing.
Nothing, right.
I'm out, I need you to go. I need you to go clean up and get your mask back on. Because in the world of COVID, what we're saying is that everyone could be COVID positive.
Right.
Until we know otherwise, until we have a process where maybe every admission gets the test, you don't know how that's gonna look with testing and all of that, is that we're telling people, you should treat this person, because coding, this process, and bagging is massive viral spread. So one of the things we're talking about initially is you get them on, shock advise, and it may be hard as you're in there by yourself and you want to come in, but you can go and grab your mask, get your goggles on, and then come in and bring this in next. That's one of the things that we have to look at what the process would be for you guys to have N95 mask PPE readily available. Everyone should have their goggles anyhow. And if you have this mask, that's better than nothing, right? But getting in there and then good quality chest compressions for the first 2 minutes, the shocking, 5 minutes. If we don't have an advanced airway, then we may have to bag, because all the research says is that the oxygenation is still really, really good, even up to 5 minutes. So maybe we're holding off on bagging, because bagging is a very huge aerosolizing process. I don't know about you guys, but when I bag, to really get a great seal, you truly need a 2-person. You need someone really cranking that mask down and someone just doing the 6 to 8 breaths, that slow process. So it may change. If you don't know the COVID status on a patient, I would treat them as if they had it. Goggles, get your mask. If you don't have it protected because you may not be, and all of a sudden they code, step out, grab a mask, come back in and be part of the team. And the first person, it feels horrible when you're out there, but you're like, let me get my mask on. Let me fix my duck bill, let me do all the stuff I need to do. It is what it is right now. So we know that's not the normal way we ran codes, but it will be the safe way, and that may look very different in the future. So we are putting out a document. One, we put out a document how to code COVID patients. That is on the intranet site if you want to look at that. And then there is another one on patients who we don't really know, and how that looks, because nothing is worse than getting exposed to something trying to
Save a life.
Exactly right. So it will look a little different, I think, in the future. And as these PPEs, that should be part of the leadership. And where do we have ours? Do we have some PPE here? That would be great, because you just never know.
Right.
So I would ask that. That's the $1 million question of getting PPEs, but there should be enough for every unit. And if not, I'd have your leadership call Lindsay Turpin or Josh Plumby to say, hey, we're going to be seeing patients. We need to have at least a stash of this so that my team could use it. That's why you don't need 8 million people in the room either, right? Only
Right.
people that really need to be in there.
Right.
Don't waste our PPE if you're
Right.
just standing there.
Yes.
What other questions?
If you're not in the middle of analyzing or getting close to when you're gonna need to, there's no harm in bumping it back to monitor from AED.
There's
or
no
to do
hard,
that type of-
absolutely. And if you feel good with monitor, that is perfectly
You can
fine.
keep it on.
You can toggle back and forth, and even in the monitor mode, you can hit analyze at any time.
Okay.
It doesn't take out the function. It's just that some people, if you don't like all the and it's too much, if you're just like, is it a shockable rhythm or not? And that is perfectly fine. But if you have it in monitor, you can absolutely hands off and analyze in monitor or defib mode at any time. And this Zoll, as long as the patches are on appropriately, will tell you continue CPR, no shock advised, or shock advised, charge. And that's it. It's good to play with this because it's the worst thing in the world is what you're used to doing here. And then you're asked to recycle a blood pressure. You guys know how to hit the fast BP on this?
One of the soft buttons there.
It is, but look, this is the easiest one. There's the soft button, you'd have to go, okay, let me turn it on, let me get to NBP. This will give you a blood pressure in 2 seconds. This right here. That's all you need to worry about. Because sometimes I get on those soft pads and I hit the wrong thing and it goes to the next trace model and I'm like, ah. That's an easy, that's your blood pressure right there. And then if you get ROSC and you're breathing or they haven't decided to tube, or maybe by that time anesthesia is there, you've moved the thing down there on the airway, that is when, if they're an inpatient, we need that inpatient team. Because we need to have a destination for this person, which is going to be ICU.
Right.
So that's why calling that inpatient team is paramount, because then it gets the proper team that is in charge of getting this patient where they need to go next. And then you'll have respiratory therapy, being able to bring you a vent. And that's the one of the things that we're looking at in the COVID world, is get them on a ET tube and get them in a closed circuit vent as soon as possible to reduce the spread. And that's how we run the COVID codes. If we have to intubate them, is on our floors, like on North 9 and North 6 and 5, where they're really heavy COVID patients right now, we have vents already on the unit. Totally different than it used to be, just so we're not bagging and spreading anything else. And they have the HEPA filters and all the attachments and all of that. HEPA filters are also on low volume, as you guys, everything is on, what is it called? You only get a certain amount and you can't get, it's the world right now. That'll change in a little bit. Other questions?
Questions? You guys have any questions? Now's the time.
We can do it again if you want. We can randomly just hit the alarms and just see how it goes. But the good news is keep that card out. Yeah, that's always fun, isn't it? And get your Zoll in and defib if it says defib. Calm voices, no yelling. And because it's okay for me to get up here and go, I have the airway. And make eye contact with the code leader so that they know, or you can say code leader, one of that B is in. And that's as high as the voice is new. And it's like the kindergarten teacher. When you talk like this, everyone gets really freaked out. When you go, okay, everyone, ready, we're turning the patient. Because everyone starts going. Versus the yelling or getting hit in the face with a random isolation gown. I'm like, oh my goodness, it's getting crazy in here. All right, any other questions? It's good to practice this. You guys have the skills now, and you can do it on your own. It's good to practice at your ACLS. It's good to practice the camaraderie, the equipment. What do you do? How do you get them on? That turn and pad and that defib, that's really the saving grace, because that time you're going to get team members who run codes all the time. I used to think I was really good at codes because I was in the MRICU for so many years. That's really a controlled environment. They're already on event. They're already on this. I got really good at it when you had to walk into chaos and you had to learn what to do and you had to really know how to work this stuff. That was the greatest thing. So practice makes perfect. And I'm far better now than because I always wanted to do the meds during your code. I got the meds. Because I wasn't skilled in doing all the other stuff, right? That's what I did. But now I'm better at it because you have to do it and you have to work in chaos. So the more you practice and the more you get used to just trick ones, what if the code happened on the other side? Is there a code card over there?
They all live in the middle.
They all live here. So think about that. What if you have a patient that gets ready to get up and they're getting ready to get discharged and they have to go to the bathroom? And they are on the floor down in that bathroom. What does that look like? You run a code on the floor. You have to turn them, but you don't need a backboard because that floor is your backboard, so you don't have to worry about that. But that becomes a whole new world of difficulty, right?
Right.
Because they're and we run codes in bathrooms, you'd be surprised more often than not in the cardiology floor. Because they have cardiac events while they're going to the bathroom. Yep. So think about that. How do you get that in there?